Good morning, good afternoon, and good evening, wherever you are. My name is Ashraf Haddad, and I want to welcome you all to the first IFSO video case report webinar of uh, 2025. We have exciting cases today. As you all know, these cases were already submitted and published in obesity surgery, and each case of them was voted to be the best case of the month for that issue of obesity surgery. I want to remind you all that you could submit your questions to the Q&A chat box, and we will relay them to the speakers at the end of the presentation. Also, you could view a recording of this webinar at the IFSO YouTube channel and IFSO Virtual Academy. So briefly, let me introduce the panelists and presenters. I don't think any of them need to be presented. They're all known to all of you. Our panelists, Dr. Aparna Goval-Bhaskar from the Saifi Hospital, Mumbai, India. Welcome and thank you for being with us today. From Athens, Professor Lenas. He works at the Metropolitan Hospital at Athens, Greece, and he's an associate professor of bariatric surgery at the European University in Cyprus. And our presenters, by orders of their presentations, Dr. Muhammad Hani. I'm sure you all came across his exciting videos and publications at obesity surgery from Alexandria University. We have Dr. Guillermo Borges from the International Unit of Bariatric and Robotic Surgery at Atlantic, Columbia. And last but not least, Dr. Wang. Dr. Wang is at the BMI Medical Center, China Medical University Hospital. He is the director of the Department of Metabolic and Bariatric Surgery. I'm going to leave you all with the first exciting case of Dr. Muhammad Hani, which is a video demonstration of the conversion of one anastomosis gastric bypass to a sleeve gastrectomy for a patient with protein calorie malnutrition. Dr. Hani, all yours.
Thank you so much. Video demonstration of conversion from one anastomosis gastric bypass to sleeve gastrectomy in a patient with protein energy malnutrition. A 54-year-old female with a history of one anastomosis gastric bypass was referred to our clinic complaining of weakness, dizziness, and watery diarrhea. She underwent the surgery in June 2020 outside our hospital with a body mass index of 41 kg per meter squared, and started complaining of watery diarrhea 3 months after surgery. She was prescribed loperamide and a pancreatic enzymes preparation, but could not tolerate them due to cost. She was not consistently taking her multivitamins. During the evaluation, the patient's BMI was 26 kg per meter squared. There was mild lower limb edema, and she underwent a thorough workup by a multidisciplinary team, including psychological, psychiatric evaluation, nutritional assessment, lab tests, upper and lower gastrointestinal endoscopy, CT scan, and abdominal ultrasound to diagnose and exclude any potential treatable cause of diarrhea, such as lactose intolerance, bacterial overgrowth, inflammatory bowel disease, and vitamin deficiency. Her lab investigations showed low levels of albumin, ferritin, hemoglobin, calcium, and vitamin D3. Upper gastrointestinal endoscopy showed no hiatal hernia, patent both afferent and efferent loops, a negative H. pylori test, and no bile in the gastric pouch or esophagus at the time of examination. And lower GI endoscopy showed no abnormality. CT abdomen and pelvis with 3D reconstruction showed one anastomosis gastric bypass with a pouch of 250 milliliter and upper bar dilatation, and wide gastrogenostomy of 4 centimeters. The discussion with the patient involved correction of the lab abnormalities through nutritional support, including enteral nutrition and admission for total parenteral nutrition and micronutrient supplements. The following was followed by the patient. Correction took 1 month, with increases in the levels of the albumin, hemoglobin, and calcium. Several surgical options were discussed, from reversal to normal anatomy, shortening of the biliopancreatic limb, and conversion to RYGP with short periopancreatic limb. Afterward, the patient opted to reverse the surgery with the intent to maintain weight, so the decision was made to revert to normal anatomy whilst leaving the pouch. The patient gave her written informed consent following explanations about the indications for reoperation, possible complications, possible plan changes intraoperatively, surgical reinterventions, and the implications for future bariatric and metabolic outcomes. In Jan 2022, the patient was admitted for laparoscopic reversal from one anastomosis gastric bypass. The surgery began with adhesiolysis. We separated the residual stomach from the gastric pouch. Followed by the counting of the entire small intestine. A periopancreatic limb was 250 centimeters. And the common channel was 320 centimeters. The reversal started by horizontally dividing the gastrogenostomy anastomosis on the endomesenteric side of the jejunum. A side-to-side jejunogenostomy is created to avoid compromising the lumen of the jejunal loop. Followed by the removal of the remnant gastrostomy anastomosis from the proximal pouch. Then resizing of the proximal pouch was done over a 40 French calibration tube. The excluded stomach was dissected to prepare for resection, creating a sleeve as the patient's request for weight maintenance. Followed by creating a side-to-side stapled gastrostomy between the proximal gastric pouch and the antrum of the gastric remnant. Then we created a new sleeve using linear staplers to resize the remnant stomach 1 centimeter lateral to the anastomosis. Closure of the stoma was achieved with the 3O BDS V-lock barbed suture. Reinforcement of the stable lines was also done with the same type of the barbed suture. Glycation of part of the remnant stomach was also performed to increase restriction. A leak test was conducted using both methylene blue dye and air. Hemostatic oxidized regenerated cellulose was applied to ensure homeostasis. A tube drain was inserted. The duration of surgery was 100 minutes. The post-operative period was uneventful. On post-operative days 1 to 3, the patient tolerated oral fluids well and vital signs were normal. The tube drain was removed on the post-operative day 4. A CT scan of the abdomen with oral contrast was performed and no contrast leak was observed. The patient was discharged on the post-operative day 5 and prescribed chewable multivitamins and oral powder protein supplement. 1 month later, the patient tolerated fluids and a soft diet and the diarrhea had stopped. At 1 year, the patient's lab findings improved and the BMI was 27 kilograms per meter squared. This is the schematic presentation of the surgery. Conclusion. Conversion of one anastomosis gastric bypass to sleeve gastrectomy is feasible in cases of protein energy malnutrition with adequate preparation. This technique allows for the maintenance of the weight achieved while resolving the complication. The tailoring of the management plan, including preparation and surgical options, must be individualized on a case-by-case basis according to the presentation.
Thank you, Dr. Hani. Excellent videos as usual. I'm going to start with one question. Have you considered conversion to a proximal Roux-en-Y gastric bypass, which with a very short BP limb, like 20-30 centimeters? It's easier and less technically demanding than a gastrogastrostomy and reconstructing a sleeve. For the people that are not as good as you, what's your thoughts?
Okay, thank you, Dr. Ashraf, for this excellent question. Yes, we thought of something like this, but for this patient, yes, we know it's a frail one and it took too much time with us for preparation and it's also suffering. So we don't want to risk any malabsorption. While it worked in the literature in many hands of many surgeons, but for us, we thought like this, that we don't want anything or any element of malabsorption that maybe it will not be appropriate for these patients in the future. So, and also, you know that many people with the gastric bypass, we have many variation in the technique inside, which is the stoma or the small size of the pouch, that it's the way it will be the same, or we need like a jump in an improvement of parameters after the surgery. So we don't want another, like to say, a slab or something make us got back to a more preparation or more supplements. So that is our thought from the start.
Thank you. I'm going to open the question to our first panelist, Dr. Aparna Bhaskar. Any comments?
Dr. Hani, wonderful video and great skill sets. I just had one question. This patient underwent a revision within 3 to 4 months of the primary surgery. Is that right?
No, she was complaining of diarrhea 3 months after surgery.
Okay, all right. And
for 1 year.
Okay, I just want, the question was that basically that for how long do you wait? What is the optimal waiting time before you actually consider a revision from primary surgery?
Yes, okay. You know, we have many parameters. Okay, the strategy which is called enough is enough. We need to operate is somewhat tricky and is more individualized. Okay, you have one patient with complaints, and you have patients with derangements in her labs, and patient was already tried conservative management and didn't work. So once all of these are achieved, so you need to operate. There was no time frame. Okay, you need to try first conservation. Okay, but we tried with the patient many things like modification of her lifestyle and taking her vitamins, some anti-diarrheals, but it didn't work. So I think this is there's no guidelines for the time, you need to fulfill the following, that it's enough, the conservative management failed, and the patient complaint is still present, and with effort, we started or succeeded to climb the bad lab findings. I think climb over the lab findings. So I think this the time it's according to your judgment.
Thank you.
Thank you so
Mohammed.
much.
Dr. Linus.
Thank you.
Your comments.
I would like to.
And sorry, Dr. Linus, for all the audience, please send your questions in the Q&A box.
Perfect. Thank you. I would like to congratulate Professor Hani and his team for this wonderful case of revisional bariatric surgery. It is a perfect example that difficult revisional cases can be done if the patient is well prepared and if surgery is performed by skilled and experienced surgeons, bariatric surgeons. I have many questions. I will start with 3 questions. First of all, was it the only case you performed? Do you have any more experience in this type of surgery, this technique? And if yes, what is the main danger? Which anastomosis is the most, let's say, the most dangerous to have a leak after? The second question is about the size of the anastomosis, respective anastomosis. What's the respective size, in centimeters? And my third question is, why did you perform an additional plication? I mean, it's a restrictive procedure, and you add a plication to that, and you have numerous anastomosis, so this might increase the danger for a leak. How do you comment on all that?
Okay. For the first question, did I have experience or I did some surgeries like this? Yes, I have at least 7 or 8 cases, okay? Conversion from raw or one and smooth gastric bypass to gastrogastroscopy like this, sleeve gastrectomy, okay? The indications in 2 patients with something like this, the protein energy malnutrition and maintaining the weight, and all the others for the weight regain. Conversion of RYGB to a sleeve, it's not a common thing, but it's maybe considered as a stage for SADI, to convert RYGB for recurrent weight gain to SADI. Maybe some people prefer to do it in 1 stage, but for me, I'd like all the time to do it in 2 stages and see the results. If we need a second one, so we can go for this. And I'd like to also to share my experience. Maybe it's not published yet. It's already all these patients did good and lose too much weight. So I think this is an ideal technique. This type of anastomosis, yes, it's risky, like you are saying, gastrogastrostomy, it's a risk, but with meticulous dissection, with like say preserving the blood supply from the lesser curve side, I think it will work. And I think also one of our colleagues will now share video with the endosigning green, maybe can let you have more comfort, or you can put, like to say, the jewel on the crown at the end of the surgery, the final step, to check the blood supply of this anastomosis. Okay, that's one. For the second thing, the size of anastomosis for gastrogastrostomy or from the start for the one anastomosis gastric bypass?
No, I mean the size, yeah, of all the anastomosis. What's the size you prefer?
Okay. In one anastomosis gastric bypass, I think the usual or the most common techniques followed by surgeon is from 3 to 4 centimeters. So we have more balance with restriction and flow. Okay, if you it's more wide, like you have less restriction, sometimes less bireflux. Okay, if you too tight, like 2 centimeters, you have more dysphagia, something like this. But I think the balance between 3 and 4 centimeters, maybe it's preferred by my side. Why I added plication? I add plication in a certain area. So it's not more for the sake of increased restriction and more alignment of the pouch, nothing else. And I think it's this step did not impinge on the lumen or encroaching upon this. So this is my thoughts. And at the end, we tested this, and we also told the patients maybe we need upper GI in the future to see if the reflux is present or not, if you have complained, but she didn't complain. So we are lucky, and this is a point. This is a good point that you raised by your side.
Thank you very much for the answers.
Thank you. We're short on time. We have to, sorry, Linus. So we have to take questions from the audience. And first question, Dr. Muhammad, by Dr. Rafael Arias. Do you have any problem with the previous vagotomy? So what they're probably asking is, if the vagus was compromised in the previous surgery, what do you do? How do you check in it? Do you do an intraoperative endoscopy to look at the pylorus, or do you just do it and then if there's a problem with the previous vagotomy, you deal with it later?
This is an excellent question, I think, but I didn't do anything extra except that you know that the vagus, maybe it's not ranged from the first surgery, but I think in this surgery, this area, maybe not, we didn't touch it, okay, at the first thing. And the second thing that you know that the vagotomy may have deleterious effect on the motility and on something, but I think with time, these things can be ameliorated because we will not have the vagus itself is the only thing that is responsible for motility. We have many things, but my practice is just did it like this and see if something happened. Maybe we can do something like pyloroplasty or other something, other maneuvers.
Excellent. I myself, if I'm reversing a bypass, I do an intraoperative endoscopy and the pyloroplasty if the pylorus is not patent. Now, another question from Mustafa Dawoodi. He's asking about the BMI in the index surgery and why BP 250 centimeter. But I think you were not the primary surgeon. She came to you for revisions, correct?
Yes, correct. But you know, Dr. Ashraf, that the counting itself maybe sometimes differs from one surgeon to another. Okay, so I think from my side that maybe he counted wrongly, maybe or something, or he is the practice to do something like this because you have surgeons to do from 150 to 250. So maybe this is the cause, but it's not diabetic also.
Thank you. And the final comment from Dr. Bart Turensama, just saying, excellent work, Dr. Hani. Dr. Muhammad Hani, thank you for all your videos. We would have discussed it much more, but our other colleagues are waiting for their presentation. Now, allow me to present Dr. Burgess from Colombia. He's going to talk about the use of ICG in SADS, and hopefully at the end of his talk, he would comment on the use of ICG in cases similar to the one Dr. Hani presented. Dr. Burgess, presentation all yours.
Hello, thank you for the invitation. My name is Dr. Guillermo Borjas. I'm representing Latin America. I'm going to talk about the role of indocyanine green ICG during the SADS procedure. I have to say thanks to my team, Dr. Sanchez Pernauto, Antonio Torres, Carlos Ferrini, Jorge Eduardo, and Ali Urdaneta. First of all, I want to talk about the key points. The role of ICG during the SADS is described on the highlight, the step-by-step of ICG during the SADS procedure. And in this paper, we're going to talk about ICG was shown to be safe and useful during bariatric surgery in morbidly obese patients. An introduction, indocyanine green is a non-toxic dye with rapid hepatic clearance. ICG has been used in medical application. It's not new since 1950, and it's widely used in abdominal surgery. ICG usefulness in bariatric surgery is still being explored, and the SADS procedure benefit from ICG in identifying the biliary tract is assessing tissue perfusion. Our propose is to study and examine the role of ICG during the SADS procedure and remark the highlights and its benefits in improving surgical outcomes. Our methods, we studied 22 patients with morbid obese patients underwent for laparoscopic SADS primary procedure. The ICG dose was administered following the guidelines, and the ICG was used for bile duct visualization, real-time arteriography, and leak testing. This is our video, fluorescence role in SADS. First, we want to make a safe duodenal dissection because we must avoid injuring the duodenal tissue because it can cause complications. Here we can see the short vessels, and we can identify the right gastric artery because, in my opinion, it's important to preserve the blood supply of this area. And you can make the dissection looking the right gastric artery directly and avoiding lesions of this important blood supply. Here you can see in the arteriography the right gastric artery. And when performing the dissection with any problem. We can avoid making injuries in the duodenal tissue. After we like to identify the biliary tract, because we're not going to perform the duodenal section is important to visualize, to look the biliary duct and to avoid complication. It's not common to make lessons in this area, but to teach this procedure to residents, in my opinion, it's very important to have landmarks and avoid complications. The duodenal section is one of the most important parts of the surgery. We can look directly the biliary tract before doing and obtaining 3 or 4 centimeters of duodenum to make the future anastomosis and avoid tension. ICG tissue perfusion, we can evaluate the tissue of the previous sleeve gastrectomy and the anastomosis, the duodenal ileal anastomosis, and the tissue perfusion of the duodenal stump. ICG blue methylene leak test, we know that the pylorus is intact in this surgery, and sometimes the pass of the blue methylene is not good to the limbs, but if we use ICG mixed with blue methylene test, we can look the passage of ICG to the limbs without any problems. And at the same time, look for perforations. And the results, all patients had a safe dissection, unidentified vascular structures, biliary tract identification helped avoid injuries, no complications related to ICG were observed in this group. All patients recovered with no transoperative or postoperative complications. The discussion, ICG improved the safety and efficiency of series procedure. It aids identifying critical structures and ensures tissue perfusion. ICG use is a promising tool to avoid complications and standardize procedures to teach this procedure to new generations. Useful tool for novice surgeons performing the first series cases. As a conclusion, we can perform with ICG in series procedure, safe duodenal dissection, preservation of vascular and nervous structures during duodenal dissection, identification of the right gastric artery and variants of its origin, prevention of bile duct injuries, evaluation of perfusion of the distal duodenal stump, evaluation of perfusion of the duodenal ileum anastomosis, and evaluation of patency and thickness of the duodenal ileum anastomosis. Thank you.
Thank you, Dr. Borges. Excellent technique and excellent demonstration of anatomy. My question to you, I personally usually divide the right gastric artery if I'm doing a duodenal switch or a SADIS to make the sleeve and the duodenum to medialize it, go medial. Have you seen any difference in your experience with the perfusion if the right gastric artery was divided or not, or do you save it routinely?
Thank you for your question, doctor. No, in the data, there is no difference between selling the right gastric artery or preserving. But in my opinion, when you are doing the surgery, preserve always the arteries. If you don't have tension in the anastomosis, it's primarily to obtain a blood supply to this area.
Thank you. Now, going back to our panelists, Dr. Linus, what's your thoughts?
Thank you, Dr. Borges, for this excellent video. This is, I truly believe in ICG. I use it in my practice, and your work is more evidence for the use of ICG in bariatric surgery. I have a question regarding the sequence of ICG injection for SADS in your practice. How many injections, how you do it? I mean, just some more information on that if you can comment.
if the patient don't have any problem of allergy, first 1 hour before surgery, we introduce 2.5 milligrams to see the biliary tract in the surgery, because it's important the clearance of the biliary tract. And after, inside the surgery, if we want to make an arteriography, we can use once or twice or whatever we want to see what are trying to look. If you want to see the right gastric artery, we use arteriography, only 2.5 milligrams. And in a second, so you can see the arteries. And if you want to repeat it, you can repeat it whatever you want, to be sure.
Thank you.
Thank you. Thank you. Dr. Gover Basker, Dr. Aparna, any comments on your end?
Congratulations, Dr. Borges. I think it was a wonderful video. Just a broader question. How many times has using ICG really altered your decision making during the procedure?
Sorry, can you repeat the question?
By using ICG, compared to when you were not using ICG, how many times has it made any difference to your decision making during the procedure? Has it made any real difference?
In my personal practice, I try to use ICG in all my studies procedure, because to teach to the residents is good to have a landmark, because they always are scared. This surgery is very demanding for beginning surgeons. So to teach the residents, I love to have me. You can look the bile duct, you won't injure the bile duct, you won't injure the wall of the duodenum. So in my personal practice, I use always ICG in this procedure.
All right. Thank you so much.
So a couple of questions from the audience. Dr. Mustafa Dawoodi, Dr. Maroon Tome, both of them are asking about the timing of ICG, which you have just answered. Dr. Emmanuel Segurumales, he says, I also think preserving the right gastric artery helps preserve better innervation of the pylorus so that it functions correctly. I am not sure about this part. Dr. Borges, any comments on your end? Do you think that preserving the right gastric artery helps function of the pylorus, or any of our other panelists?
We have the great opportunity to learn this technique from Dr. Anthony Torres and Sachs Pronaute, the fathers of the surgery. And the problem is not only the blood supply. The nerves are very important, because we want to preserve the pylorus function. So we must evaluate in the future if we selling the right gastric artery with damage the function of the pylorus. For me, that's very important too.
Excellent. Now, what would you do if you did this beautiful anastomosis? You gave ICG, and the anastomosis did not light up on ICG. Would you just leave and see what happens? Would you just dismantle your SADIs and do a Roux-en-Y? I mean, what would you do? I've had a case like that. One of our greatest surgeons, Dr. Kelvin Higa, once showed a video of an anastomosis that did not light up after a SADIs, and he left it, and the patient did okay. So your thoughts?
See, I have to sell the right gastric artery 2 or 3 times because of tension, to avoid tension and big patients with morbid obese patients. So in this case, we can see the duodenum with change of color, something like brown, black, okay? But I didn't change my approach. I go with the surgery, I go here, and don't have any problem right now, since right now.
Yeah, it does happen to all of us. And finally, Dr. Hani's case, do you think ICG would be useful in planning?
I have experience doing that kind of revision, the reversals to normal anatomy and to gastric sleeve. Yeah, I believe that's very important to use ICG in that kind of surgery, because we have some corners of ischemic parts we can evaluate. So it's very important, in my opinion, to select the area using ICG to find the proper part of the stomach. We can make the stapling and then future anastomosis. I prefer to do anastomosis, Hansu, the gastroanastomosis, Hansu.
Okay, thank you so much. Excellent video. And now allow me to move to our final presentation of the day. We have Dr. Wang from China. He's gonna present about the revision of Roux-en-Y gastric bypass to sleeve gastrectomy with a proximal jejunal bypass. This is probably not common in let's say the Middle East and Jordan, and probably not common in a lot of areas, but seems more common in the Asia Pacific. Dr. Wang, all yours.
Hi, friends of IFSO. I want to thank the invitation from the IFSO to give them chance to talk about revision of the bypass to sleep with proximal jejunal bypass and hiatal hernia repair. This is a video that we submitted about 1 year ago, and we get the best VCR from the obesity journal. I'm CK Huang from Taiwan, China Medical University and China Medical University Hospital. This is a case of bypass revision. First, I want to say bypass has some early and late complications, including the short-term and long-terms, such as the loss of access to the remnant stomach, dumping syndromes, marginal ulcers, internal hernias, and also anemia and some vitamin deficiency. Most of the long-term complications are related to some nutritional deficiency, require long-term vitamin and mineral supplementations. And we also observe more dumping syndromes, especially in Asia group, we have more carbohydrate consumption. So the dumping syndrome has been reported to affect up to 40% of the patients. This is 51 years old females. The body height is 161 centimeters. About 10 years ago, he has a BMI 44.3. Then we performed gastric bypass Roux-en-Y fashion for her. That time her weight was from 115 kilos, then lost very good weight loss to coming down to 68.5. The BMI going down to the 26.4. But 10 years later, the patient come back for follow-up. We found the patient developed severe dumping syndromes. Immediately after eating, she has abdominal pain, diarrhea, and also showing some bilateral leg edema because of hypoalbuminuria, anemia. So she also, in the lab test, we saw that it's iron deficiency anemias, mild hypoalbuminurias, and also hypokalemia because of frequent diarrhea. So our surgical plan for her is revision the gastric bypass to 3 base procedures. The patients in the beginning, the BP limb is 120 centimeters and elementary limbs is 120 centimeters. Then the bowel total length for common limb is 5.1 meters. And then we are going to convert to the sleeve with proximal jejunal bypass. So we will reserve the previous 120 BP limbs, and then we will make another 180 common limb. So the total length of the absorption becomes 3 meters. The other become the blind loop. Okay, so let's see the video.
Revision of laparoscopic Roux-en-Y gastric bypass to laparoscopic sleeve gastrectomy with proximal jejunal bypass and hiatal hernia repair. The patient is a 51-year-old female who had undergone an laparoscopic Roux-en-Y gastric bypass procedure 11 years ago for obesity 3. However, the patient developed dumping syndrome, suffering abdominal pain and diarrhea immediately after meals. Bilateral leg edema was noted, and diuretics were prescribed by the physician. Preoperative laboratory tests revealed anemia, hypoalbuminemia, and hypokalemia. Our surgical plan included gastrojejunostomy resection, sleeve gastrectomy, and distal alimentary limb transection. These were then followed by gastrogastric anastomosis and jejunostomy for proximal jejunum bypass. After liver suspension, adhesions were dissected along the liver, proximal alimentary limb, and gastrojejunostomy. The hiatal hernia was also dissected. After identifying the hiatal hernia and left and right cruise, the hernia was repaired with 3/0 acetone suture. After adhesiolysis, the gastric pouch, bypass stomach, and proximal alimentary limb were all identified. The alimentary, biliopancreatic, and common limbs were all counted. The alimentary limb was transected proximally. Sleeve gastrectomy was performed over the gastric pouch. The great curvature was dissected, all the attachments until the pylorus were free. The gastrojejunostomy was removed by transection via the gastric pouch. A gastrostomy opening was created at the bypass stomach, and the oral gastric tube was inserted. Sleeve gastrectomy of the bypass stomach was performed. The hands-on method was used for gastrogastric anastomosis with 3/0 monosyne suture. A continuous running suture was used for the posterior wall. Another stitch was used for the continuous running suture of the anterior wall. The anterior wall stitch was discontinued at the middle of the anterior wall. The stitch used for the posterior wall was sutured across the angle and continued to the anterior wall. The two stitches were tied together at the middle of the anterior wall. The anastomosis was tested for an air leak under saline solution. The gastric tube was fixed to the retroperitoneum with 3/0 vicryl suture. The esophagus was fixed to the right and left cruise with 3/0 monosyne suture. The omentum patch was used to enforce the anastomosis. The distal alimentary limb was transected. For proximal jejunum bypass, a jejunum was constructed 120 cm from the ligament of Trice and 180 cm from the ileocecal valve, creating a 300 cm common limb in total. The enterotomy defect was closed with 3-0 monosine suture. The mesenteric defect was closed with 3-0 acetone suture. Finally, a JP drain was put beside the gastric tube and gastrogastric anastomosis site.
So this is the video. I hope that everyone enjoy it. The patient after the revisional surgeries, no more dumping syndromes, and also all the nutrition was improved. The iron deficiency also is not there. So I think that to convert the bypass procedures patients with some long-term metabolic nutritional complication to sleep-based procedures is a very reasonable revision option, and then can correct most of the complications that we don't want. Thank you very much for your attention.
Dr. Wang,
Yeah.
thank you so much. Interesting revision. So I'll reserve my comments till the end, and let's start with our panelists. Dr. Aparna, what do you think of this procedure to treat hypoglycemia and malnutrition?
Excellent video, Dr. Wang. Dr. Wang is the pioneer of Sleeve Plus procedures in Asia, and he's a teacher to a lot of us. So, congratulations, Prof. I just have two questions. One is that this patient had a very large hiatus hernia, and we've done a sleeve-based procedure. Would you think that it will increase the incidence of reflux in future? I know you fixed the crura and everything, but still. And the second would be, what would be your nutritional supplementation protocol? Because I think what we have is only about 300 centimeters of bowel, and the remaining 480 centimeters is being bypassed. So do these patients also experience a lot of protein deficiency and other nutritional deficiencies?
Okay, thanks Aparna's questions. Very nice. I thought study-based procedures, including the like SADIs or duodenal switch. In fact, we in Asia mostly we incorporate sleep plus mostly like sleep with jejunal bypass or proximal. You can call proximal jejunal bypass because you did not bypass duodenum. So in fact, 3 meters common limb is from the stomach to the terminal ileum. In fact, we did not observe the malnutrition issue like even gastric bypass patients. So in the first year, in primary this kind of procedure, we support the same vitamins as sleep and bypass patient, the same dose. But after 1 year later, we routinely do vitamin checkup. Then if everything is normal, we will lowering the dose to half. After 1.5 years, if everything normal, then the vitamin supplement is not necessary. But the patient still need every 1 year come back for follow-up. This is our standard protocol for C+ procedures. About the reflux, the patient before surgery, we do pendoscope. They showing this heart hernia already. So that case, we during operation for revision, we open the crura and fix it. And but of course, sleep-based procedures mostly they have more reflux, as the literature is showing. So I think that you still need to be very careful before surgery. That if the patient have showing the reflux, have the weak cruras, you in the operation you have to repair it. Then of course prevent the problem of the when you convert to sleep, if you cause some structural functional problems, then I think the reflux will happen. So that's the reason why I don't like to do the side-to-side osmosis for this revisional surgery. Most I do end-to-end. I think the passage of the fluid will be more smoothly going down. And then during operation, do not injure the vagus nerve is also very important. So identify the vagus nerve during operation is also a very critical point.
Can I ask one more question?
Yes,
Great.
go ahead.
So, what would be the incidence of diarrhea? Because this bowel looks really short to me. Do they get any diarrhea post surgery?
Frankly speaking, the patient don't have diarrhea.
Okay.
With this primary procedure and also revisional procedures, because I think duodenum for absorption of fat is still the most important things. So when you see the sleep with proximal jejunal bypass, in fact, the patient did not experience any diarrhea.
All right. Thank you so much.
Thank you. Dr. Linus.
Thank you very much, Dr. Huang, for this wonderful revisional case. I have three questions. First of all, what was the duration of your surgery for this patient? Second, how do you prepare preoperatively these patients? What are you doing as exams or preparation? And finally, what happens when you have a leak in one of your anastomoses? What are you doing after that? What was the next step? Thank you very much.
Okay. In fact, how we prepare this kind of case, in fact, till now, I have done about 10 cases of this kind of gastric bypass complications. We really experience one leak and one strictures. And for the leak cases, we do reoperation, go into repair, and then put the feeding jejunostomy in the blind loop. Then after about 2 weeks later, the patient can discharge with good recovery. Stricture case, we need to do the balloon dilatation for the patients. So I think this kind of case still on some higher complication rate because seraph dissection, including the total hands-on osmosis for that, and impair the circulation after you dissection and cut the sleeve. And high pressure system also is one of the issue. So I think for this kind of case before surgery, I always have do more careful. If the patient have hypoalbuminemia, the iron deficiency, and we will correct the patients. Especially for those with albumin less than 3.2, we routinely support albumin to be enough values, then we do surgeries. And most of the patients after bypass in Asia, they can lose good weight. So you see these cases, BMI is only 26 for revision. It coming from because of complication. So we don't have big patients for revision in this kind of patients. So that's how we manage the patient.
Thank you. Dr. Borges, this is interesting. You know, someone with hypoalbuminemia, you revise them to a procedure with even shorter bowel. Any comments on the excellent video of Dr. Hang?
Thank you for the question. I prefer to do in these cases total recovery of the anatomy, but because if the patient continues with the problem of iron, with the problem of anemia, what you can do? So, in my opinion, if we have a problem with the gastric bypass, a severe problem of malnutrition or deficiency of iron or anemia, I prefer to make a normal anatomy back. And that's my personal opinion.
Thank you. Dr. Hani, Muhammad Hani, you do a lot of revisions. What's your thoughts on GI bypasses? We're doing a more malabsorptive procedure to treat someone with malabsorption hypoalbuminemia.
In my opinion, and I don't have enough experience about these procedures, okay? In our area, we didn't do this, but here also I have some concern about the blind jejunal loop. I think it's too long, so I don't think that is, maybe it's a problem or not. Maybe Dr. Che can tell us about this. But for me, as I like Dr. Borges had said now, I think the reversal, maybe if it's severe hyperemia, is better than this procedure.
So thank you. So Dr. Wang, two things. My personal experience in getting people that are malnourished is that number one, they take a lot of time to prepare preoperatively, several weeks. Sometimes they need for TPN if the albumin is low. Number two, if they're a long BP limb Roux-en-Y or a one anastomosis with a long BP limb or even a SASI procedure, I try to either offer them conversion to normal anatomy or revise them to a proximal Roux-en-Y with a 20 centimeter BP limb and 70 centimeter Roux. However, I do understand that you constructing a sleeve will help with the hypoglycemia or the dumping syndrome that the patient was suffering from. But how would giving a patient a total alimentary limb length of 180 and 123 meters be a treatment for hypoalbuminemia when they had 500 and 120, almost 6 meters of total alimentary limb length? And then I have seen this recently. Surgeons around the world they have revived the jejunal bypass, and I think history has taught us that the jejunal bypass is not a really good procedure. So why revive it with all the other procedures that we have in our hands these days?
Okay. Jejunal ileal bypass procedures are totally different with this jejunal bypass because it's 100 centimeter common limb versus 3 meters common limb. It has a very big difference. I would tell you that the previous jejunal ileal bypass created a lot of malabsorption, so the patient experienced a lot of diarrhea 5 to 6 times a day. But for this jejunal bypass, mostly you did not see any diarrhea. We have done almost 3,000 cases. And then Munia Alamos, he has done these procedures almost 20 years. He has published the data about Brian-Luke syndrome also. We do this procedure almost 10 years. We did not see a Brian-Luke syndrome too. So I think this is not a really malabsorption procedures. According to the hypoalbuminemia problems, if the patient with bypass develops some malabsorption problems, then mostly I would just convert the common limb to lengthening the common limb. I think that's all. But if the patient have severe dumping syndromes, bother the quality of life, then you have to consider to revise to the sleeve-based procedures. Whether you want to convert to studies or like a duodenal switch procedures, or like we do duodenal jejunal bypass with loop fashion or Roux-en-Y fashion, I think all you can do it. But the problem is bypassing duodenum spare the pyrotic functions. Mostly the patient have the problem of the malnutrition issue and also the dumping syndromes. So that's the reason why I convert to sleeve with proximal jejunal bypass. And I think that is need to think about whether we just can convert to sleeve only or need to add in the proximal jejunal bypass. I think that's the most important question that we should answer. But sleeve alone, in our experience, the patient long-term weight regain is much more compared with these procedures. Because the hormone study showing the sleeve still worse in the GLP-1 enhancement compared with sleeve plus the jejunal bypass procedures. So that's the reason why we do like this.
Okay, so at the end of this, let's take the questions from our audience. Dr. Mustafa Dawoodi is saying, if you wrap the omentum around the GG anastomosis, would that increase the proximal pressure in the newly formed sleeve and cause a leak? Any thoughts?
No, I thought that would not cause the structural issue or the compression over there because the omentum is just a loose fix over there. We did not make a ring, make a structure over there. So I think it's not a problem.
Okay, we have Dr. Pham saying that with the JI bypass, which we don't see a lot from in North America or the EU, not even in the Middle East region, are you not worried about this long 480 centimeter blind limb and all the complications that come with it in the future?
I think that I have answered this many times in different surgical forums. Till now, we do almost 3,000 cases. About 10 years experience, I never experienced any blind syndrome. In Taiwan also, there's no surgeon ever revised this kind of case because of blind syndromes. So I think bacterial overgrowth in this kind of case seems not there. And we would closely observe this kind of whether the complication happen with even a longer longer blind loop. But I think the nutrition issue is still one important thing, that if the patient did not develop malnutrition problems, would be not have the hypoimmunity that like the jejunal ileal bypass caused the hepatic liver failure problems. So let's look into the long-term results. I think that it will give us the answer.
I think that's important because if you look at the history of the GI bypass, people decompensated 20 years plus after the bypass. When they're young, they have a high muscle mass and they're active and they eat well, they're okay. Then when they're a little bit older, they get one episode of pneumonia or cellulitis and then they decompensate fully. So would be interested to see your longer follow-up data. We have Dr. Nabaz Barazinji saying, have you got any strictures, stenosis, reflux with your gastrogastrostomy? I thought, I mean, you mentioned this. Can you just mention it again briefly for him?
Yeah, I think that the same thing, that this could be causing some reflux, but in our experience, if you cross the crura carefully, then it's not an issue. But leak can happen in about 1 case in our 10 cases. So during operation, you can there's another option for that. For the revision, I think that maybe you can do 2-stage if you worry about the complication for the leak or strictures. Then it's another option for that.
And then another question from Dr. Natalia Savala about bacterial overgrowth. You have already answered. Dr. Tai Convoy says, for Roux-en-Y complication, instead of surgical reversal, what about creating a gastrogastric fistula? I'm thinking he's probably talking about endoscopic options. Anybody has experience with that, creating an endoscopic gastrogastric fistula to reverse a bypass? No?
Yes, we have one case. We did endoscopically ultrasound.
Yeah.
We put a metal opposing stent. I think maybe we can publish this case and we can share it. This was like a case with severe protein energy malnutrition, not intractable, and it's not ameliorating with any type of conservation. And we did, this is the least thing for her, and I think she's recovering now. After she finished everything, I think we will show it.
Excellent. At the end of this webinar, allow me to thank you all for being here. I would like to thank our panelists for sharing their knowledge, comments, and their time, and our presenters for taking the time to share these wonderful videos. Thank you, our audience, for interacting and for your questions. All these presenters are invited to present in the video case report session in Chile for IFSO, and I hope we see you all there. Again, one more time, just to remind you, if you haven't got the chance to watch this webinar, you could see it at our YouTube channel and in IFSO Virtual Academy. Thank you all.
Thank you so much.
Thank
Thank
you.
you.
Bye-bye.
Thank you.
Bye. Bye.
Very much.